It is my privilege to be moderating our discussion this evening, where we'll be talking about women's health, and in particular, why it's still so difficult to talk about some issues in women's health, even in 2024. So, Halle, you've been working tirelessly to change the way we think about menopause. Yes. And this work was really inspired by an experience you had at the doctor's office. Can you share that experience with us?
Oh, God, I'm afraid you were going to ask me this. Okay, are you sure?
I am sure.
Okay, guys, I'm sorry to every man in this room, but you got to hear it.
Very important.
It is very important, but it's very graphic, so I'm just going to warn you. I got inspired to do this work because I was 54 years old, and I found out that I was smack dab in the middle of menopause. It was something that nobody ever talked to me about, my mother included. My ego thought, because I'd weaned myself off insulin at 24 years old, I'm a type 2 diabetic, I thought, I'm healthy, I eat right, I'm just gonna skip this menopause. This isn't gonna happen to me. And by the way, I don't even know anything about it, so I'm sure it's not gonna happen to me. Well, all of a sudden, 54 years old, after being divorced 3 times, sorry, but it's true, I meet my person, the man of my life. He's sitting right there, Van Hunt. I meet Van Hunt, and we're having the most amazing relationship, and sex was a great part of it. Everything was going fine. So one night, we're having sex, and it's great. Seems like nothing in the world is wrong until the next morning when I go to try to use the bathroom. I sit down, try to go, and it's like I have razor blades in my vagina. Like razor blade, a cutting, burning feeling when I let a little bit out, then I squeeze, then I let a little bit more out, then I squeeze, and it takes me like almost 10 minutes just to empty my bladder. I think, oh God, what is going on? And then about an hour or two later, the most heinous substance you would think to excrete from anybody's body starts excreting. And it's all colors, and it has an odor that we won't discuss. And I think, oh my God, what happened in 24 hours? So I call my gynecologist. Yeah, I gotta come in, I gotta see you right now, I'm having a bad problem. I go there, he, does the thing, he's got me up in the stirrups, he's looking up there, he said, oh God, I think I know what this is. I said, really, what? He said, you have a new partner, right? I said, oh my God, I finally met the man of my life. He said, I don't know if this is the man of your life. I was like, why would you say that? You don't even know him. He said, because you have the worst case of herpes I have ever seen. I'm like, what? Herpes? He said, yep. I don't think this is the man of your life because you've been given herpes. So now the man of my life who gave me these herpes is sitting down in the car because my vagina is so on fire, I couldn't even do the pedals to drive myself to the doctor. So the man who gave me herpes is sitting in the car waiting for me. So you can imagine my fury. I get down to the car, see the man that gave me herpes, and I'm like, yo, you got fucking herpes? When were you gonna tell me you had fucking herpes? He says, I don't have herpes. I'm like, clearly you do, because now I do, and I didn't have herpes before I met you. So clearly you have herpes. He says, nope, I don't have, nobody's ever told me I had any herpes. I said, well, let me be the first to tell you. You've got herpes. He said, no. Well, then he's such an empath. He goes, well, maybe somebody gave me herpes along the way, and I just, not everybody knows they have it. They're silent carriers, I said, well, it's not so silent now. You're a carrier, and I'm here to tell you, you got herpes. He goes, well, I'm going to go to the doctor. I'm going to get this checked out. I'm not so sure. I said, yeah, go. Find out you got herpes. So he goes and he gets checked out. I'm waiting for my results in 3 days. He gets his results first. He comes to me chest out. Guess what? I don't have herpes. I guess you have herpes. And luckily, you didn't give it to me. I'm like, wow. All right, so talk about putting your tail between your legs. I'm thinking, how the fuck did I get herpes? My doctor calls me later that same day. He tells me, guess what, Halle? You don't have herpes. I'm like, I don't have herpes? I'm like, why would you tell me I had herpes? Do you know what I just went through for the last 72 hours? He said, well, I don't know, that's what it looked like to me. And this is the moment when I realized something was going on with my body. I was in perimenopause. I did my own research. Even my doctor then didn't say, oh, my bad, it's not herpes, it's actually perimenopause, it's vagina atrophy and your vagina is dry, and that's what it is. And if you have sex, when your vagina is dry, you can tear up the inside of your vagina, and this is what it would look like. He didn't tell me that. I had to go do that research for myself and figure out what exactly was happening to me and what I could do for this vaginal atrophy so that I could continue to have a sex life with my partner. And that was the moment when I realized if I had such little information, and I have the best doctors in California, and he had never even brought the subject of menopause, and the sexual part is one small part of it. There are much more health implications that go along with a woman going into menopause. But I thought, if I didn't have access to this information, how many women in the world don't have access to this? And how many women are suffering in silence? How many women are feeling ashamed? How many women don't talk to their doctors about it, or they get misdiagnosed? And that was a moment that I knew I had to stand up for myself, because by standing up for myself, I'd be standing up for every other woman. And that became my second life act, my second life passion, and I'm giving my life over to it. So sorry, I told you it was graphic. It's a graphic story.
It's a vicious cycle, isn't it, of misinformation and lack of information
Yes.
and stigma
Yes,
that all feeds
stigma.
into itself.
And it's so much more than just our sexual health. You know, it's just not, bikini medicine below the waist. One of the biggest things I just would like to say, what I've learned is that, women, we have hot flashes, and so many, mostly men, think, oh, it's just hot flashes. I mean, so what? You're going to be hot for 4 or 5 years. No, some women flash for 2 decades. And every time you have a hot flash, I've now learned, you're actually having a little mini stroke. And when you have a little mini stroke, you get these nodules on your brain. And if you study a brain of a woman who has Alzheimer's today, it's full of these little nodules. So you find out why it's so important that we not have hot flashes. It's not just because they're uncomfortable, it's because they're doing something very detrimental to our brain, which affects our health as we go through midlife and the aging process.
I think that's a very important lesson for all of us to take away this evening. Marlena, you also have a very personal experience that guided your research into morning sickness. So tell us about that journey.
Yeah, so most pregnancies are affected by morning sickness, but I had something much more severe, similar to Kate Middleton and Amy Schumer. Maybe you've heard of hyperemesis gravidarum. And so when I got pregnant, I was so ill that I could not move without violently vomiting. I just had to lie completely still on my back. I couldn't drink even water. And it lasted for weeks and weeks. My doctor put me on IV fluids. Then he tried different medications, nothing worked. Eventually he tried 7 different drugs at once and nothing worked. I ended up on a feeding tube. And when I had the feeding tube, I started to feel a little bit better just from having energy, but it was too late and I lost the baby in the 2nd trimester. And through that whole horrible experience, my doctor told me that I was just trying to get attention. And I was too weak to argue with him. I actually, at one point, had to use a buzzer because I couldn't speak anymore. I was so weak. But after I recovered, I do have a PhD from Harvard in genetics. I was already focused on women's health issues. I found the first gene for uterine fibroid tumors. So I decided to... So I decided to work on finding what the real cause of hyperemesis was. And I didn't have it in my family, so I didn't know if it was genetic, so I had to start from the very beginning and see if it ran in families and do a familial aggregation study. And then I spent the last 20 years searching for the cause, finding the gene, and the latest paper that just came out in Nature figuring out how that gene works. And now we're on the pathway towards a cure.
Dan, we've just heard about 2 issues in women's health that really don't get a lot of attention, and really 2 women who were dismissed from the medical system. You represent a big pharmaceutical company. Tell us a little bit about how we can ensure that women's voices are heard and the issues that are important to them are part of the drug development process.
Yeah, thank you, Alice. It's great to be here with both of you and hear your remarkable stories. Thank you for sharing them. Of course, at a pharmaceutical company, we want to help all patients that are suffering. Unfortunately, there's a number of diseases that disproportionately affect women. And so oftentimes our focus does turn towards what we can do to help women. Maybe I quickly talk about two diseases that you may not think of as women's health issues, but actually they are, starting with a disease I've worked on my whole life, which is Alzheimer's disease. Most people don't think of that as a women's disease, but in fact, 2/3 of people with Alzheimer's disease are women, simply because, fortunately, women live longer. And unfortunately, Alzheimer's is an age-related disease, so as you get older, more likely to get it. Not only does it disproportionately affect women as patients, it turns out that the vast majority of people who are caregivers for Alzheimer's patients are also women. So when we think about the cost of Alzheimer's disease to our society over the next couple of years, it will be $5 trillion in lost productivity and direct costs, of which 75% will be borne by women. So it's incredibly important for our Alzheimer's trials, for example, that we have women participate in the trials. With 2/3 of the Alzheimer's population being women, you would think it wouldn't be a problem, but it quickly turns out it is. Although we are able to get more than half of the patients in our trial as women, it's difficult, more difficult than you would expect to find them. One of the reasons why is that women are often diagnosed later, probably for some of the same issues that both of you spoke about, that the medical community sometimes is less likely to take symptoms seriously in women. Probably also because women have what we call perhaps a higher cognitive reserve. They're better at things like verbal memory, which is one of the first signs of Alzheimer's disease. So for women, the signs show up a bit later in the disease course. And so by the time they come to trials, they may be too advanced. So we've done a lot of things, for example, in this field to encourage participation by women patients, including trying to make our trials less onerous on the patients, having them able to be conducted from home, trying to the extent possible, decrease the requirements around caregivers to come, because men who have Alzheimer's often have a female caregiver. Women who have Alzheimer's may have less of a good support structure. So that's one disease that we're working hard on to help women. The other is a disease you've heard a lot about in the press. It's obesity. It affects men and women, both, of course, but it affects women differently. It turns out obesity in women is more driven by food cravings and by hunger. Women are more likely to seek treatment for obesity, but also less likely to be taken seriously by their doctors. Even so, in our clinical trials for obesity, we have the opposite problem, which is that women preferentially enroll in our trials. We have to cap their participation to make sure we have some men in the obesity trials, and men often wait until they have other symptoms of disease before they come to get treated for obesity. So we're looking at diseases that are common across the population, but trying to understand specifically how they affect women, how we can hear women's voices in our clinical trials and address it with treatments.
And recently, President Biden has issued an executive order to prioritize and more seamlessly integrate women's health issues across the federal research spectrum. Marlena, I wonder if you could just briefly tell us how much of a difference is that going to make for example, for scientists like yourself and the work that you do?
I hope for scientists like myself it will make a big difference. I did apply for an ARPA-H grant, so we'll see in the next month or so. But yeah, I mean, one of the reasons that I'm the world's researcher in hyperemesis gravidarum is not because I'm so great, but just because there is no other researcher, and it's so hard to get funding in this field. So putting that money out there is going to inspire other people to think about women's health issues and fit them into their whatever they're studying so that we can get more progress in that area. So yes, I think it's fantastic.
And on the subject of governmental support, Halle, you have been working with some Congress people and have proposed legislation to focus a little bit more on research for menopause. Yet Congress is 72% male. Is that a problem?
That's a problem. Yes, so that's why my approach was to go to all the females in the Congress and hope that I could get them to come together in a bipartisan way and put us first for once, because this lack of study on the female body in midlife is long overdue. So I right now have 18 of the 25 that are sponsoring or co-sponsoring the bill. There's a few that are still holding out, you know. And if we can get all 25, I feel like with some House members, and there are some great men on the Senate side that are very much behind this, but there's still some women that are holding out. And to my dismay, their trepidation is that they feel like the money that's already allocated from the NIH should be just shuffled around. But we know, and I've learned through my research, that menopausal women and women in midlife never get the money. There's always something more important. So my goal is to have new appropriations and have $265 million, that's what's the teeth of our bill, have that money be allocated towards menopause and women's midlife health. And I think then we'll have real dollars to do real research so that scientists can do all the trials that they'd like to do. And I think that's the only way we're really going to start moving the needle, is to make sure we have money allocated just for us at this time.
And Dan, one of the reasons why we still have so much stigma around certain women's health issues is lack of information, right? And historically, women have not been included in clinical trials for good reason, for issues of safety, especially women of childbearing years. Can you tell us about what can be done or what is being done to address that and include more women? Is there technology? We've got great science now. Are there ways to get those answers without putting women's health at risk?
Yeah, I think the scientific challenges around conduct of clinical trials in women are largely addressed. I think with the exception of women of childbearing potential, it is really about educating physicians mainly that we have to spend more efforts there so that we can have better participation of women. I think we can often overcome it in clinical trials, but then when we come to launching a new medicine or making a new technology available, again, we face the kinds of ignorance or discrimination that both of you spoke about. One example is our work in migraine, another disease that much more commonly affects women. Because it's subjective, a lot of times women present to their doctor with migraine, and the doctor ignores them or says, you're just seeking attention. There's all sorts of these behaviors that we talk about as medical gaslighting, where doctors are actually disbelieving their women patients. And so we have to do a lot of work to educate them, because of course we want these great medicines that we've created to be used to help patients. So that's also part of the role of the pharmaceutical company, is to change medical practice. One of the ways that we can do that is by working with female doctors disproportionately in our clinical trials, because we know that they're more likely to offer more equitable care to women patients.
And part of our bill, our Senate bill, will be also to allocate dollars so that doctors can go back and be further educated and retooled, because I was horrified when I found out that in medical school, doctors there's only one chapter on the menopausal body. And this is something every single woman will face if they're lucky enough to live that long. And there's one chapter, and most of them don't even remember it. So that's also what our bill will be for, to get doctors further educated so they can be retooled.
I think that's critically important. I was going to say that, this gaslighting, Dan, that you mentioned, it does seem to be an embedded issue. And Marlena, if you want to comment on whether you've seen, since your experience, has the needle moved at all? We're in 2024, and it's still astounding that we're hearing doctors tell women these things.
I mean, I wish it was moving a little more than it has. I did get a tape from a medical student who had hyperemesis, and her professor, who was a female doctor, OBGYN professor, told her and told the class, so this is the whole next generation of doctors, that when patients are hospitalized with hyperemesis, it's usually because there's something going on at home, or they just don't want to get better. That's really what she taught the students. So there's a whole next generation of doctors that are learning this. So we really need a re-education. It's really important.
One thing that I think we've seen that helps sometimes is when there's a new treatment that's introduced, then people understand that what they actually saw as, maybe the patient's fault is actually a disease. Historically, this happened with diseases like epilepsy or even tuberculosis, where it was blamed on the patient. More recently, it was depression, where doctors would say, chin up, think positive thoughts, until we had medicines for the disease, and then doctors changed. Today, we're seeing it in front of our eyes happen with obesity, where we used to blame the patient. As soon as there's medicines available, doctors start understanding that it's really a disease that can be treated.
Well, and my doctor also told me, when I told him I've diagnosed myself, I realize I'm in perimenopause, he said, just deal with it. Like, white knuckle it. It's only going to last 5, 10 years if you're not lucky. Okay.
Easy for me.
Not good enough. Not good enough.
Not good enough, for sure. So in closing, and this is one of the things that I love about TIME100 is I get to do this. Halle and Marlena, you have here, sitting right next to you, Dan, who is at a major pharmaceutical company.
We thought of that.
He's male.
I volunteered for this.
Yes. But he's also pretty influential from what I hear at the company. So here's your opportunity. You have his ear. What advice would you give him about finding ways to prioritize and ensure that women's voices are heard? I know
First,
Dan's
believe
open.
them when they tell you something's wrong and that they're not making it up, which I think you do.
And I mean, you have a drug actually that would help for hyperemesis that you guys are not, it's kind of shelved, you just told me. So I have a very specific request. I'm ready to test it to desensitize women.
I'm sure we'll find a way to work together.
I think you just got your marching orders, Dan.
Glad.
Thank you. Well, Halle, Dan, Marlena, thank you very much for joining us in this dialogue.
Thank you for
Thank you for having me.